gives me great pleasure to welcome David Garets, another of our international keynote visitors, General Manager and Executive Director of the Health IT Suite, a division of the Advisory Board Company of the United States, but also with an office here in Australia in Sydney. And David has extensive experience at the most senior level in a range of leading organisations in this field, and he's internationally respected as a thinker, speaker and author in healthcare information strategies and technologies. Please welcome David Garets.
I acknowledge the traditional custodians of the land upon which we stand. Good morning, everyone. This is my 9th appearance at a Healthy Nation conference. I think I hold the record. I'm happy to be back. This is my 18th trip to Australia in the last 16 years. So I've been watching what's going on in Australia for a long time in the e-health space, and I've been watching it in Europe, and I've been watching it in the Middle East as well as in the United States. So what Sally asked me to do today was talk a little bit about what's going on in the US, what's meaningful and accountable. I'm going to talk about 3 different things. I'm going to talk about we're broke. I'm going to talk about what meaningful use is, which I think is an interesting concept. And I'm going to talk about accountable care, which I think is an even more interesting concept. Winston Churchill said at one point that you can count on Americans to do the right thing after they've tried everything else. And that is so true, especially in the healthcare delivery and financing arena. We have 50 million of our citizens who do not have health insurance. We have 18% of our gross domestic product taken up by healthcare. We have 100,000 people every year who die from avoidable medical errors. We are not a good example on any of those measurements. But I think, and those of you who've heard me speak before know that I'm not real happy about it, and I'm pretty critical of the progress that the United States has made over the years in terms of in cost and quality of care. But having said all that, I actually think that the US government has figured it out. I think what they're doing with meaningful use and what they're doing with accountable care are something that is not only is the right thing to do, but I think is going to make us much better in healthcare delivery and much more affordable healthcare delivery. So here's the dilemma that we have that's on this slide. We've got to figure out how to cover everyone in the country with health insurance. But at the same time, we've got to figure out how to make it affordable for not only those folks, but also for the people that are turning 65 every day. And right now in the United States, there are 7,000 people who are turning 65 every day. I will do it in 437 days, but I'm not counting. And then what happens in the US is you get off of commercial insurance, assuming you have commercial insurance, and you go on Medicare. So the US government has got to figure out what it's going to do about Medicare. And so does it need to raise taxes? Does it need to reallocate spending? Does it need to revamp the entire healthcare delivery system? Well, the answer is all of the above, and that's what's going on in the country right now. These are some of the initiatives that actually started in the Bush administration. You wouldn't know it from reading the papers and reading what the Republican candidates for president are saying about Obamacare, but a lot of the stuff that happened with payment reform happened in the Bush administration. For example, never events, which is, okay, we amputated the wrong legs, but we get reimbursed for that. You know, not anymore, you don't get reimbursed for that. So they've broken the code on that. There's hospital-acquired conditions that up until this year, hospitals and physician practices got reimbursed for, no longer. There is a readmissions program that's kicking in a few days in the United States, so that if you are discharged from a hospital and you come back within 30 days, the hospital doesn't get reimbursed for the next time they see you. So there are profound IT implications of all of these things. Meaningful use started in 2011 and goes until 2015. It may go beyond that. And oh, by the way, we're actually going to move to ICD-10. We are the last, as I understand it, developed country in the world to move to ICD-10. We have complicated it significantly. We've also delayed it. They are now, my guess is they'll move it out a year, so we'll have to do it in October 1st, 2014. But it's a huge deal because you're going from somewhere, I can't remember the exact number, somewhere in the vicinity of 12,000 to 13,000 codes to somewhere in the vicinity of 160,000 codes, because the US has a different version of ICD-10 than anybody else. So we've got some significant IT and business challenges that are facing us, not the least of which is a completely revamped way of reimbursing healthcare delivery organizations. Here's what it looks like. So if you are a hospital and you have been making money in the American system all these years by sucking up to the physicians, getting them to admit patients to your hospital as opposed to the competition hospital down the street, and the sicker they are, the better. The more of them there are, the better. You're going to get your health system turned on its head, because what is going to happen in the accountable care environment is that instead of wanting to have patients in your hospital, you want them out of your hospital. You don't want them showing up in your hospital because you're a cost center. I completely agree with Ricky in his assessment that hospitals are dinosaurs and we're starting to see the end of them. I think it's going to take 3 to 4 times longer than any rational adult would think it would take. I think it's going to take that much longer for that to actually occur. Hospitals, at least in the United States, have the money and have the influence in the community and are the largest employers and all that kind of stuff. And they're the center of the healthcare universe in the United States, and I think in some respects they are here too. It's going to take a long time before they stop being the center of the universe. But all the things that you were doing to make money now don't make you money. And the biggest challenge facing healthcare organizations in the United States now, at least from a management perspective, is being able to manage your organization through that 180-degree flip. Because you've got to make money and got to make money, got to make money, and all of a sudden you got to make money, only you don't get reimbursed for fee for service. It's not, all you do, you get reimbursed for. It's keeping people well, paying attention to the patients, trying to keep them out of the hospital, managing their chronic diseases in an outpatient or in a home environment. And that's what's going on in the United States right now. So let's talk a little bit about meaningful use. It came about as a part of the stimulus package to try to kick us out of the recession. And I thought that was kind of funny, given that it goes through 2015, 2016. I'm hoping the recession doesn't go that long. But there are 3 basic tenets of meaningful use. What you're supposed to do is you're supposed to adopt certified technology. So there is an independent commission, or several of them actually, that certify applications from the vendor community. You will have these capabilities. You will follow these standards. You will do these things. You will have this capability in your system, and it will be able to communicate with other systems that are not manufactured by you. Well, needless to say, hospitals and physician practices are pushing on the vendors in a big way, because you don't get your money in terms of the meaningful use refunds that you get. You don't get your money unless you're using certified technology. So the Allscripts and the Epics and the Cerners of the world are heads down making sure that they have systems that are certified. Then you have to demonstrate core and menu set requirements. I'll talk about that here in a little bit. And then you have to report on quality measures. This is truly meaningful use. It's not slam systems in and say, okay, nurses and docs, you work here and you will now use these systems, and expect everybody to salute and expect something to happen. This is, you will get meaningful use and adoption out of the technology that you implement. And if you do that, we will give you some money. If you don't do that, we will take some money away from you. And oh, by the way, the money that we take away from you is a lot more than the money that you will get by achieving meaningful use. So there's a carrot out there for a while, and then all of a sudden it turns into a great big stick. And I quite frankly think it's the right thing to do. In stage 1, what they were trying to do is increase the implementation and adoption of electronic, and I will call them electronic medical records. What they're talking about are the systems in primary care offices, specialists' offices, and hospitals. And what they're trying to get those organizations to do is to capture structured data. I think that is crucially important. If you don't have structured data, it's going to be pretty hard to share with patients the data that they are going to be asking for in personal health records. Stage 2, which just got announced about a month ago, and there's a comment period going on right now, it tries to get healthcare organizations to increase the exchange of health information from one entity to another entity, demonstrate care coordination, which is a significant thing to get done, and empower patients. All of which are lofty goals, but they've got very specific things that they expect you to do, and I'll go through some of those here in a second. And then in stage 3, and there may be a stage 4, but in stage 3, what they're going to do is they're going to drive outcomes. You're going to have to prove outcome improvement. This is about technology, but it's also about driving costs out of the system, being more efficient, more effective, engaging patients more, as you will see here in a second. So we're about halfway through this at this point. The NPRM for stage 2 was released, like I said, about a month ago. If you look at the top pie charts, however, the number of organizations who have gotten the stage 1 money, and it averages, by the way, for a hospital, it averages about $8 million. So it's not a trivial amount of money. They've allocated a total of, I think it's $34 billion for this program for all hospitals and all physicians in the United States. There are better than 5,000 hospitals, and I think there's somewhere in the vicinity of 700,000 physicians in the United States. So it's not, quite frankly, a huge amount of money for what they're trying to get done. But 17% of hospitals in the United States have gotten their stage 1 money, have qualified for it. That means 83% of them haven't, and I will show you a slide having to do with the EMR adoption model that will describe for you why they haven't. If you look at this laundry list of critical elements, there was a comment yesterday about the focus in your program as opposed to others is point of care. I would argue that a bunch of this stuff is point of care. There's allergies, discharge instructions, vital signs at discharge. What they're also doing is a care transition summary and plans for the next provider. There's care plans, there's lab tests available at the type of discharge. There's the listing of the providers is what they're going to mandate healthcare organizations do in stage 2 to get the stage 2 money. And like I said earlier, if you don't do that, then you get penalized. And the penalties are significantly more than $8 million per healthcare organization. So this is all meaningful use of electronic health records is what this stuff is focused on. And it's why I said I actually think we've broken the code on what we need to do. Here's some interesting stuff. So they're expecting that 50% of discharged patients are going to have their information available online within 36 hours, so a day and a half. Get it done. Make it happen. 10% of patients at that point, you have to be able to document that they have viewed, downloaded, or transmitted their information to a third party, not you, somebody else, in that reporting period for stage 2. And what I've heard from CIOs in the United States is this squawking about, well, how are we going to get patients to do that? We can't tell patients what to do. No, the answer is you have to inform patients that they can do it. And once you do that, of course, the gates are open, and now you have to, it may not be 10%, it may be 90%. You got to figure out how you're going to do this, because the rule says you will do this or you won't get the money. And so they're forcing the issue, and they're trying to get patients engaged with the clinicians in that regard. And then 10% of summary of care records are electronically transmitted using EHR, certified EHR technology to other entities. So let's say your Cleveland Clinic, for example. You have to be able to, the patient has to be able to send those records, or you have to send those records to another entity, not Cleveland Clinic, and 10% of your patients have got to be able to do that. So there are some significant IT implications of all of this, as you can surmise. Then they're going to have clinical quality measures. In stage 1, what they did is they suggested that eligible hospitals had to measure 15 different quality measures. That's jumped to 24 in stage 2, and for eligible professionals, and by that they mean docs and other care professionals, they went from 6 to 12. So you have to not only use the system, so clinical documentation, you have to be able to generate reports on your quality. Again, this is meaningful use. And then there's real-time data capture that's required. So problem lists, care transition summaries, the care plans that are being developed in healthcare organizations, the list of care providers. Most of these things are not being done in American hospitals or with American providers up to now in the way that they need to be done going forward. So problem lists, by the way, are handled by the Health Information Management Department for the most part. But now stage 2 of meaningful use says you will use SNOMED for that. So, okay, if you haven't got SNOMED implemented and you haven't figured out how you're going to translate what you're doing in the HIM department to SNOMED code and be able to report on it, then you better figure that out. Discharge summaries, there are a lot of healthcare organizations in the United States that don't get those done within 36 hours. Well, guess what? You will get it done within 36 hours or you don't get paid, and if you don't do it by 2014, 2015, you get penalized. So there's some teeth in this stuff that I think is really interesting stuff. Here's the EMR adoption model, or at least what the scores were, the percentages were in the United States since Mike Davis and I invented it in 2004. The 2005 numbers, which aren't on here, are actually worse than the 2006, but I'll tell you what they are. And the stuff that I want you to look at are these numbers right here. The ones at stage 4 and above. Those are the important ones, because those are the ones that are healthcare organizations that have mostly implemented an electronic medical record in their environment. And in 2005, the total percentage of hospitals that were stage 4 and above was 2.51%. At the time that the meaningful use stuff came out, the stimulus legislation came out and the program started, the number of stage 4 and above was about 11% of hospitals in the United States. Right now it's 27 or 28%. The program is working. Organizations, it is forcing the issue. Organizations are implementing the technology, they're getting adoption, and they're getting meaningful use out of information technology to support care across multiple entities. So it's real interesting to watch the stage 4 and above organizations as we keep moving towards stage 2 and stage 3. The 1.2% of stage 7 organizations, by the way, I think that's 62, it may be 63. 36 of those organizations are Kaiser facilities. And there's not a lot, obviously in stage 7. If there's 28% of hospitals in the United States that are at stage 4 and above, which are the organizations, by the way, that can get the stage 1 meaningful use money because they've got CPOE implemented, which is what stage 4 is. That means that 82% or 72% of hospitals in the United States don't have the applications implemented, which means there's a whole bunch of places that better get the lead out, quite frankly, and start doing their implementations and start getting meaningful use, or they're going to be in some trouble here in the next couple of years. So that's why I think only 17% of hospitals, eligible hospitals, have gotten their stage 1 money so far. By the way, the amount of money that's been handed out is about $3.4 billion so far. Let's look at accountable care, because that's a really interesting thing. This came out of the Bush administration. This is not a Democratic Party idea. But I'm a Democrat, but I think this is the right thing to do. What this does is it looks at performance risk, it looks at utilization risk, it looks at quality of care, cost of care, and volume of care. And they're going to start reimbursing healthcare organizations, including physicians, differently in the accountable care world than they do now, and now is fee for service. So there's pay for performance, so you have to demonstrate the quality of the care that you delivered, or you don't get fully reimbursed. And by the way, it's not optional. You will do it. This is mandatory in the United States. Then they're going to move into bundled pricing, which I will describe, that gets to performance risk. So are you as efficient as you can get in how you deliver care to patients across a continuum of care? And then you get to utilization risk, so you're trying to deal with the volume of care that you have. And that's what the accountable care environment is. Quite frankly, the cynics, and I'm one of them, that talk about this say that the reason the US government is doing this is because we're broke. We simply cannot afford to have the percentage of the gross domestic product that's associated with healthcare get to 20% or 25%. We'll go broke. So this is figuring out how to save money, how to get costs out of the system. If we can improve the care that patients get and we can improve their experience and we can keep them well, great. But the name of the game here is to drive costs out of the system. At least in my view, that's the first priority. So here's how it works. It's not going to be the same for every healthcare organization in the US. It's going to be different in some regions than it is in others. There's going to be organizations that are going to take to this like ducks to water, including organizations like the Cleveland Clinic and Kaiser and Group Health Cooperative and organizations like that. I agree again with Ricky on there's going to be consolidation, and hospitals that are not going to survive are going to be standalone, relatively rural hospitals with 100 beds or less. They're going to have to figure out how to partner with somebody in order to survive. So in the pay for performance in the lower left-hand corner, like I said earlier, this is mandatory. This is get it done, it's in place right now. That's how healthcare organizations in the US are being reimbursed. There is some pay for performance associated with the reimbursement. Then there's the hospital physician bundling. And in the US, it's real entertaining. A lot of the physicians in the US don't work for the hospitals, right? They're independent business people, kind of like they are here. And so what they've decided to do, and John will appreciate this, so I need a hip replacement, and so John admits me to the local hospital. I have my hip replacement. He charges, and I'm making this up, $5,000 or $10,000, and the hospital submits their bill for submits their claim to Medicare for that. And so the grand total is, let's say, $15,000 between the physician who does not work for the hospital, they're an independent business person, and the hospital's billing for their OR suite and that sort of thing. So the government says, okay, that's nice. We're going to reimburse you 12.5. So you guys figure out how to divide it up, because that's all you're going to get. I don't care how many of these you do, you're going to get 12.5, and so figure it out. So that's a management problem, right? Now all of a sudden you've got to figure out how you're going to enter into a relationship with John and make sure that he's happy, because you still get reimbursed for doing those hip replacements, but you don't get reimbursed as much. And you've got to figure out what works and what doesn't work. So it's real important to start implementing protocols, clinical decision support, to be as efficient as you can get, because all you're going to get reimbursed is 12.5, and you got to figure out how to divide it up. It's an IT problem too, because most of the revenue cycle applications, in fact, I would argue all of them in the United States, are not capable of doing this. So they're going to have to replace some of the technology in place so that they can figure it out. It gets worse. It goes into episodic bundling. So I have a hip replacement, I get the surgery, and I'm in the hospital. Then I go to rehab. So the rehab facility is not owned by the hospital in all cases. In fact, in most cases. So it's a separate standalone entity. You don't control the IT of the rehab facility. You don't control John's IT, right? You control your own potentially, and you're going to get 17.5 when the total cost is really closer to $25,000. Medicare says 17.5 is all you're going to get. Figure out how you're going to divide it up. So they're driving costs out of the system. They're making the health system talk to itself, across disparate boundaries of, healthcare organizations, and they're trying to force the issue on what best practices are. And then you move into a shared savings environment where you are given, you bill for fee for service, but there's an expectation that you're going to hit certain targets for how much this stuff should have cost. And if you hit the targets, that's great. You get to share in the savings that are accrued, because the shared savings is going to cut dramatic amounts of money out of what they traditionally reimbursed and force you to get a heck of a lot more efficient. If you go over, then there are penalties, and you have to divide up the penalties in addition to dividing up the shared savings. It's pretty interesting stuff. And again, it turns the healthcare financing in the United States and delivery on its head. And it's about time, quite frankly. This is some more specifics on the pay for performance. So hospital readmissions program is one of them. Value-based purchasing program is one of them. Hospital-acquired conditions is one of them, where there are penalties, and those penalties will take effect if you are not operating at maximum efficiency and effectiveness. Here's the bundled payments. That's a bit more of a description of what actually occurs. There's various models for it. They are doing a bunch of experimenting right now and trying to figure out what actually works and what doesn't work, but they expect that this is going to roll out in the next 3 to 4 years, and healthcare organizations have got to be ready to deal with it. And then here's the shared savings program that I discussed a little bit earlier, that talks about the bonuses that you get or the penalties that you get if you don't hit targets that you've been given information on prior to a year, for example. You have been given information on, this is what we expect for these diagnoses, for diabetes patients, for congestive heart failure patients, for surgical patients. These are the expectations. If you don't hit them, you get penalized. So the ideal environment is what was referred to as the Rolls-Royce environment, which I would argue is not a Rolls-Royce environment. It's a rational environment. What you want and I'm a former CIO, what you want, if you can get it, is one database that has ambulatory information in it from your physicians that in your community, your acute care stuff, as well as your revenue cycle information, and it's all in one database where you can get access to it and it's rational. That's what, quite frankly, Cleveland Clinic has, that's what Kaiser has, that's what a bunch of organizations in the United States are implementing right now. But would it be really cool if you had that one database, and that's what this slide shows. But the trouble is, that's not the way it is. The way it is limited ability to aggregate data because you've got lack of data standards, you've got multiple tools for different clinicians in multiple environments, you've got a mess. I have found actually one hospital in the United States that has over 1,000 separate applications running in its data center. It's absolutely unmanageable, insane. You're never going to get to one, but can you get it down to closer to 150? Because most of the academic medical centers in the United States are well over 400 separate applications they're trying to run. The problem with that is that there's not good interoperability between those systems. That's the point of meaningful use. You will do these standards. You will have interoperability, and here's how we're going to execute on the interoperability. And so they're forcing the issue using the meaningful use money. And it's the right thing to do. You can't have a presentation at a technology conference without one of these slides. And I haven't seen one from anybody else, so I thought I would put in the obligatory goofy-looking slide. The point of this is these are going to be the systems that you have running in your healthcare organization or in your community, and these are the feeder systems. These are the source systems that you're going to have to manage as a healthcare organization. You're going to have to extract information out of that. You're going to have a full-on data warehouse with a full-on comprehensive data model, not bolt-on BI tools, although you will do that for a while until you get a full data warehouse implemented. Then you will be doing not only descriptive modeling out of a data warehouse where you are reporting on what happened in the past. So here's a dashboard that says, here's what happened in the last day. That's looking backwards. You will also have predictive models that look forward to say, well, what could happen? And then eventually, and a lot of healthcare organizations, at least in the States, are working pretty hard on the predictive stuff. Prescriptive is not there yet. Prescriptive says, what should you do? And what prescriptive does is it feeds information back into your source systems, so for the GP in their office, for the hospitalist in the United States, and the hospital trying to take care of the patient, feeds information back into the source system in real time, so you have real-time clinical decision support. So you have an efficient, effective, connected healthcare system that engages the patient along the way and keeps them fully engaged. You have to what the meaningful use specifications say is you have to have patient portals. They're not saying that you have to have a personal health record. They're saying that you have to have a portal, you have to give information to the patients have to use it, and you have to be able to demonstrate that patients are interacting with the health system and are using the information. Yep, this is my last slide. Boy, she's naggy. This is an important slide. I created this slide a couple of weeks ago for a presentation, and I wanted to make it really clear that there is an order in which you do these things, in my view. So the first step in the way is implementation. You've got to get the systems in. You've got to get adoption. But you have to have the tools in place where you are capturing data, which is the next step, in granular data that's standardized, which is the next step when you convert data into information. You have to have the systems in place in the environments where care is delivered, and that includes the home. You have to be able to capture the data, or you don't have anything to share with patients. And so what the meaningful use money is trying to do is trying to drive adoption of technology by clinicians and by healthcare organizations, and then generating data from it, and then generating information from the data, and then generating knowledge that can be communicated throughout the health system to improve the care that patients get and to keep them, quite frankly, from being patients in the first place. That's what we're doing in the US right now.